Good morning, everyone, and welcome to today's ARC Talks on empowering patients and navigating your care. I'm really excited to be speaking myself. I'm the CEO of the Amyloidosis Research Consortium. And joining me today is Lisa Mendelson, who is an exceptional nurse practitioner who works at Boston University Amyloidosis Center. She's been there since 2017. And any of you who've had the luck to come across her and work with her will know how extraordinary she is and how much she cares and really helps empower patients. So we'll be starting off with me doing a very brief presentation about my experience as a patient, and then we'll hand over to Lisa. And the session should last about an hour. We have the last part is reserved for question and answers. So if you have any questions, please feel free to type them in at any point into the question button at the bottom of your screen. If you have any technical issues, there's a chat button, and use that. We have a couple of the ARC team members who are in the back scenes and can push any help with any issues if you have any. So just by way of background, I wanted to just briefly introduce the Amyloidosis Research Consortium. ARC is an organization that I founded in 2015, and it's dedicated to accelerating the pace of development for new therapies and improving quality of life for patients. We have 4 areas of focus. These include improving the speed of diagnosis, increasing the understanding of the biology of the disease so that new targets can be identified to develop treatment, accelerating clinical trials, regulatory approval, which is FDA approval, and reimbursement of effective treatments. And lastly, enhancing quality of care and quality of life for patients throughout their journey with amyloidosis. I would like to thank the sponsors for ARC Talks for supporting these meetings that happen pretty much monthly. And so just briefly, I wanted to talk about my journey with amyloidosis. I actually collapsed at my wedding in 1995, and within a few months was diagnosed with AL amyloidosis. I was fortunate in that my local center was actually the National Amyloidosis Center in the UK, but the treatments that I was offered were very limited, and I was actually given 3 to 6 months to live. It was through the tenacity of my family that we discovered about Boston University Amyloidosis program. And I was one of the first patients to come over to the States and undergo a successful stem cell transplant. I've been very fortunate that my organs recovered and that I've gone on to live a full life and have subsequently adopted, I don't know why my forward buttons aren't working, there we go. Adopted 3 children, and in 2015, I formed the Amyloidosis Research Consortium. So first and foremost, I think one of the most challenging things for me is that, you have the initial experience of being diagnosed with amyloidosis, and it's something you end up having to live with and manage for the rest of your life. So it really was something that was important to me to become empowered and really learn the best ways to live with this disease. One of the first things I felt when I was diagnosed, it was almost, I liken it to being in a car crash and then having to step into an exam in a subject you've never learned. It's like sitting a Latin exam. I found that healthcare providers spoke a completely alien language to me, and I just couldn't grasp what was going on and the expectations of treatments and the choices I had to make. Getting armed with a medical dictionary was really helpful. We have, thankfully, the internet now. This was back in paper days. The other thing that was really helpful, and this was actually stolen from the bone marrow unit I was in, so it's clearly, please don't remove, but having some children's books around science and how the body works, to really go back to the basics, to understand the processes, what normal processes are like, so I could understand what was going wrong in my case with AL amyloidosis. The other thing is that when you were told not to go to Google and not look it up, I think it's the first thing we all do. We have to just recognize that. So Google wisely. And really make sure that as you're looking, there's so many things that come up now when you search for terms in amyloidosis, that you're using a reputable source. The world of amyloidosis is incredibly fast evolving. We look back at 2018 and there were no approved treatments. Now there are multiple treatments. There are many clinical trials. So if anything is more than 2 years old, it's out of date. And so really look when something was written, where the source is. And it's always something you can take to your physician and question them about, and they'll be able to give you more accurate information. Finding the right care team is critical. You do need to check your coverage to make sure that you can be seen at some of the centers that have renowned amyloidosis programs. So that's something always to check into with your insurance. But developing a good relationship with your clinical care team is really critical. You want a team that will support you on seeking a second opinion, and that's something I found incredibly challenging. I felt my care team would think less of me and care for me less well if I sought a second opinion. The second opinion is what saved my life. And my care team, when I came back, were really happy to continue seeing me and working with me and consulting with the Boston program. So it can be difficult to do, but it's really worth considering doing and making sure that your care team supports you. Additionally, being a good patient is really important, knowing what and how to share information. And I won't go into this in detail because this is something that Lisa will go into in a moment. Managing treatment schedules can be difficult. And unfortunately, medications have side effects, and knowing what these will be and how to mitigate some of those side effects is really good to talk about with your care team. Another thing is that if you have an important life event coming up, speak to your care team about that, because you can end up potentially shifting when you might be taking a treatment. You might delay something, you might move it forward, so that you can really participate in full in these life events that are important. I experienced extreme anxiety when I was diagnosed. I'd never stayed in a hospital before. It was overwhelming to have this diagnosis. There are really good tools now for managing anxiety. Some of them are online tools like Calm and Headspace. There are a number of different programs that you can do to help with breathing exercises, meditation. There's cognitive behavioral therapy. I did something called autogenic training, which really just helped me calm myself down in a time of such extreme anxiety. I think the other thing that's really overlooked is after the initial shock, and this is something I speak to many patients over the past 25 years, just I've heard so many times that depression, amyloidosis is depressing. We are having to live with completely different set of things that impact our life than we had expected before our diagnosis. We need to address that. Physicians and your amyloid team can really help you manage that depression. And it's not something to feel that is an insignificant or inconsequential symptom that you're experiencing, I call it that, but it is something to really raise with your care team. Additionally, amyloidosis affects sexual health. It can be an early symptom of some types of amyloidosis, and it's definitely something to discuss with your doctor. We see it raised many times in some of the surveys and studies that we've done at ARC, but it's often rarely raised with your physician in appointments. Do so. These teams are used to this and can really help. I think for me, outside the physical organ-related symptoms, fatigue was crippling. And I hear this from a lot of patients, and managing that fatigue is really difficult. But there are ways that you can sort of help. It's debilitating, it's frustrating. Making sure that you plan ahead, plan plenty of ways that you can build in time to rest, listening to your body and not pushing yourself, and getting support. I think we did a poor job as a young couple in getting the support we needed to help us. But it is something to really figure ways to manage, and there are good resources on managing fatigue available. Lastly, I just wanted to mention caregivers. There is a huge burden on caregivers who have to not only deal with supporting us as patients, but also their life has changed significantly when we're diagnosed. So making sure that as a caregiver, you get the rest and support that you need, calling on others to support you. There are good resources and organizations that really can help support caregivers, and it's something to really recognize that you are part of a team and you need that support. I just wanted to mention lastly that at ARC, we have a large number of resources available to help educate and support patients. Studies have shown that patients that are engaged with an organization like ARC do better. They're more likely to get the latest standard of treatments. They're more likely to participate in research and do better overall. So we have at ARC a variety of resources. We have a patient resource section on our website. We have a number of booklets that you can access online, or we're happy to send to you, that give an overview as well as deeper dive into the treatments. We've developed the MAP tool, which helps identify treatment centers that match you, as well as identifying any clinical trials and alerting you to those as they come up. And we also have a great support line. There's a picture here of Shaki, who is likely to be the one who will answer your call, and always available to help and support you. So without further ado, I'm delighted to hand over to Lisa Mendelson, and take it away, Lisa.
All right, give me 1 second to share my screen. Oh, Isabelle, you have to stop sharing.
There we go.
All right. So one of the things I wanted to talk about is, why do you as a group of patients even have to go to a webinar like this? It's pretty unfair. Patients who have breast cancer, they can just trust what their doctors say. They don't need to become experts in their own disease. But unfortunately, amyloidosis, you do, because it's a very complicated disease. There's a lot of nuances with amyloidosis. It is rare. It is extremely underfunded. It affects every organ, so that complicates it, and it's extremely misunderstood. So I feel for you all that you have to go to a webinar to figure out how to navigate your care. And we recognize that that's different from a lot more common diseases. So I'm very happy you're here. And I just wanted to thank ARC for inviting me to do this, because it is a subject that's very near and dear to my heart. This is a slide. It's just a visual representation to show how complicated amyloidosis is. So I started to notice that we were getting a lot of referrals at the amyloid center that were false positives, meaning patients would come, they'd go through the whole shebang, and it turned out they don't have amyloidosis. And this is increasing over time. Part of it is because we do a lot of outreach, right? And we're trying to get the word out. So now physicians are thinking about it, which is great, but they still have no clue how to deal with it. So you can see that in 2021, almost 20% of our referrals actually ended up being false positives. So it's not that, patients don't get the disease, like people who went to medical school don't even get the disease. So I don't want you to feel bad about, having it be so complicated. And do not despair. We all know knowledge is power, and that is why you are all here. So I hope I can be helpful. So what can patients living with amyloidosis do to help? The number one thing you can do is to know your disease. There are so many types of amyloidosis out there. And it's frustrating when I read a cardiologist note and it says the patient has cardiac amyloid. Okay, well, what type of amyloidosis is it? All the different types are extremely different. On this slide, you can see the molecular makeup of them. See how different they look? That's how different they're managed. That's how different their symptoms are. And that's how different they're treated. So you always want to know what type of amyloidosis you have. So historically, the most common type was AL, or it can be called light chain, and it used to be called primary amyloidosis. So that's not confusing at all. It's got 3 names, first of all. So this is the type that's made in your bone marrow. So this Y-shaped thing is a light chain. We all have them. We all make them in our bone marrow. And what you want to know is if you are a kappa or a lambda. So you'll see on this light chain, everybody has kappas and lambdas. You want to know which one you are. This is extremely important because we get lots of phone calls from lambdas that their kappas are going up, and we say all the time, we don't care about your kappa, you're not a kappa. So you want to know if you have AL, and you want to know which light chain is the problem. The other thing you want to know is what organs are involved. This is just as big of a deal as knowing what type you have. So you want to know, is it in your heart? Is it in your kidneys? Is it in your liver? And the only way you're going to know this is to talk to your providers and pin them down for answers. If you have TTR or transthyretin amyloidosis, you need to know first and foremost, is this hereditary? Meaning, is this passed down through families? Or is it what we call wild type transthyretin amyloidosis, which means it's a spontaneous mutation of the TTR. And again, you want to know what organs are involved. In hereditary TTR, it's often the heart and the nervous system. So it can be peripheral and autonomic nervous system. In wild type TTR, it's often the heart, but it's also in what we call soft tissues, meaning it deposits in your wrists and presses on your nerves, causing carpal tunnel. It deposits in your hands and causes trigger finger, and it deposits in the ligaments of your spine and causes spinal stenosis. And the reason that's important is because that's going to push you to talk to your providers about how to make those things feel better. I'm not sure if we have any people in the audience who have AA, but AA used to be called secondary amyloidosis because it's due to an underlying inflammatory condition. So the problem with AA, what you really need to know if you have this is, what is the underlying condition? You want to make sure your physicians have done a thorough workup to exclude any underlying inflammatory disorders. And in about 35% of patients, we can't find an underlying condition. So those are called idiopathic when we can't find one. And you also want to know what organs are involved. There's a lot of misconceptions out there about AA, that it only affects the kidney, and that is not true. All of these on this slide are systemic diseases. They can affect any organ. So that is really important to keep in mind. What else can patients do? So know your markers of disease and then train your doctors so that they know them as well. So in AL, we're looking at very specific blood work. So one of them is serum-free light chains. So that's looking at the kappas and the lambdas in your blood. Again, if you're a lambda, look at the lambda. If you're a kappa, look at the kappa. Don't pay attention to the other one. And then in bold, I have something that says serum and urine immunofixation electrophoresis. Super long name. We call them SIFIs and UFIs. But basically, that's looking for your lambda or kappa clone in your blood and your urine. This is important, and the reason I put it in bold is because a lot of doctors, and myeloma doctors and hematologists, tend to not pay attention to it. But it does factor in for the definition of remission for AL amyloidosis. So if these are not getting checked, we can't tell you if you're in a complete response or a partial response. So those serum and urine immunofixation labs are important. And then I'm sure if you have AL, you're familiar with the 24-hour urine for protein. And then we also recommend you get cardiac enzymes checked. Even if you don't have cardiac involvement, you want to make sure you're not developing cardiac involvement. And then just a basic blood count and metabolic panel. On an annual basis, if you have AL, you probably should get an echocardiogram, which is an ultrasound of the heart, and EKG, just to, again, make sure you're not developing any cardiac involvement, and a chest x-ray. You can get nodules and amyloid in your lungs. And then again, if you have AL, you're probably familiar with the bone marrow biopsy. Unfortunately, the factory for this disease is the bone marrow. That's what makes the plasma cells. That's what makes the light chain. So really the only way to see into the factory at this time is with that big needle, unfortunately. If you have transthyretin amyloidosis, wild type or hereditary, a lab that is very important that is often overlooked is called the serum prealbumin. Prealbumin is another name for serum TTR or transthyretin. So it's measuring the amount of TTR in your blood. It's important to know the numbers because that kind of lets us know if the treatment is working or not. And again, it's something that I feel like a lot of physicians who don't work in amyloidosis a lot are not familiar with. And of course, if you have TTR, you want to get your heart enzymes looked at and basic blood count. Annually, you need echoes, EKG, chest x-ray, and then other studies you might need. If you have hereditary, you might need nerve conduction studies or EMGs. If you have wild type and spinal stenosis, you might be looking at MRIs of your lower spine. So it kind of depends on what organ involvement you have. If you have AA, the most important lab you need to get checked is called SAA, or serum amyloid A protein. The first A in AA stands for amyloidosis. The second A stands for the serum amyloid A protein. That is what's floating around in your blood making the AA. So just like prealbumin is TTR and we make you check the light chains, it's very important to check this SAA level. It is a hard lab to get. It's only available through LabCorp, and a lot of local physicians just ignore it and don't get it. But it's extremely important. It's how you can figure out if your disease is getting better or worse. Also with AA, because it is an inflammatory condition, you want to get a CRP and an ESR. These are non-specific inflammatory markers that are very helpful to know if they're going up or down. Again, annually, echo, EKG, chest x-ray, and then other studies kind of depend on the underlying condition. There's a misconception, again, that AA doesn't really go to the heart. It's written that only 5% of patients with AA will have cardiac involvement, but in our patient population, we've seen up to 35%. So it's important to know that. And then the star is just every amyloidosis patient is so different. Even if you have someone who has the same type of amyloidosis as you, the markers can be completely different. Some people have very low light chains to begin with. Some people have very high. It's important for you to know your baseline, where you started, and not compare it to other people. All right, so you guys, you know all about your type, you know about your markers of disease, you're heading in for your appointment. How can I make this a good appointment? Well, first of all, you don't want to be seeing this medical student whose meme I have up here that just walks in the room, says they're going to give you chemo and walk out. That is the worst possible scenario. So again, it's a complicated disease. There's a lot of symptoms, there's a lot of side effects to discuss. Write your questions down ahead of time. This is hugely beneficial, especially for your clinicians, and helpful for you as well to kind of get your thoughts organized. And you know, you're not tied to the questions you wrote down. You can always ask other questions as well, but it's just helpful for the important ones. If you have a partner or a spouse, it's not a bad idea to query them ahead of time. To ask them if they've noticed anything or, you know, what they're worried about. So you're not like having that argument play out in front of the clinician you're seeing, because that takes time away from the visit as well. Your medications, super annoying medications. They have weird names. No one can pronounce them, but it's super important that you know what they are, you know when you take them, and you know the doses. When we see patients in follow-up, we get 30 minutes to see them. I mean, it can take 20 minutes to figure out what meds someone is on. And it's really important for us because a lot of the medications are used to help the symptoms. And so we can't tweak them unless we know what dose you're actually taking. So that saves a lot of time. If you've had any interim hospitalizations, if you've been to the ER, if you've had surgeries or illness, it's good to just have like bullet points of that so you remember to tell your care team. Even if you don't know all of what went on, then they can kind of look further into that to make sure it's not something that's pertinent to amyloidosis. So these are things that as a clinician, I just feel help the visit go a little bit better. Questions to ask. So if you have AL amyloidosis, you want to know how you're responding, okay? So if you're on treatment, you want to make sure the treatment is working. So you can ask, what is my response? There's criteria out there for your physicians that was written, and they should be able to tell you if you're in a complete response or a very good partial response or a partial response. And hopefully they would have already told you if you're not responding. So if you have AL and you're on treatment, what is my response? How is my disease doing? The other thing to ask is, how are my organs doing? Okay, so remember, organ involvement, just as important is hematologic involvement. So if you have heart involvement, what stage am I? There are 3 stages. The BU has a staging system, Mayo Clinic has a staging system. Stage 1 is the best, stage 3 is the worst, and these are important for patients because the stage actually predicts prognosis. That is something you want to know. And then what are my heart numbers? What are my BNP and troponin? Are these getting worse? Are these getting better? These are things that will, you know, as Isabelle said, there's a lot of anxiety with this disease, and the more knowledge you have, you know, the better prepared you can be for what's coming down the pike. If you have wild type TTR, you can do the same thing. You always want to know what organs are involved, and then there's a staging system for that. What's my cardiac stage? Is it 1 or is it 3? When you come to the BU Amyloidosis Center, you are always told, usually on the Tuesday you're here, what your stage is and what the prognosis is based on that. Are my cardiac numbers better or worse than starting therapy? I can't, you know, that's extremely important for you guys to know. When people come and see me on Tuesdays, I always print out their labs, and I always compare their labs to their baseline labs, meaning what they were before they started treatment. In AL, you like to see the labs get better. In TTR, you just want to make sure they're not getting worse. So that's important for patients to know and be aware of. If you have AA, what is my SAA level? If your physician says, I have no idea what that is, you say, that's the marker of my disease. Why is this not being checked? Have my organs responded to treatment? If you have AA in your kidney and there's lots of protein in your urine, they better be checking a 24-hour urine so they can tell if the treatment is working or not. So no matter what type you ask, you always want to know what your response to treatment is and how these specific labs look. I think you guys can tell I'm pretty passionate about the whole organ involvement thing. And the reason is a lot of the symptoms of amyloid come from the organs that are being attacked from the amyloid. And I feel like, you know, when not all hematologists, not all cardiologists really pay attention to the other symptoms and organs. So, you know, it is a multi-system disease. So you're going to have multiple specialists. You cannot have multiple specialists who refuse to talk, okay? You do not want your specialist operating in what I call silos. Sometimes this can happen when people are hospitalized and you start to notice things are falling apart, and it's because the teams aren't talking to each other. And that really is a disservice to you as a patient. So you want to make sure your teams are discussing things and talking to each other. It's so frustrating for patients when they see their nephrologist and the nephrologist is like, you need to increase your water, you know, you're dehydrated, your creatinine's going up. And then you see your cardiology MP and she's like, you need to limit your water. I mean, who would know what to do in that situation? So you don't want your doctors operating in silos. Again, a lot of the symptoms are from the amyloid attacking the organs. In wild type TTR, I feel like a lot of these patients have a disservice because they have a lot of spinal stenosis, the trigger finger, the carpal tunnel. They can actually lose their hand function because their carpal tunnel is so bad. And these things really aren't being addressed because people are just worried about the heart. But it's important, that's why it's so important to know what organs are affected so you can advocate for yourself, because there's interventions for these things to make you feel better. When should I worry? So this slide is not a catch-all. It's a question I get all the time, and it's very hard to answer. And the only reason I put it on here is because Isabelle made me, and I hope it's helpful, but it's a very difficult question to answer because all of you are so different. But in general, there's non-urgent things, somewhat urgent things, and super urgent things. As far as non-urgent, changes in labs. Little changes in labs are not a big deal. Little changes in labs are not things that you need to, send a patient portal message and say, I need a call back in an hour. That's not going to happen. There's someone watching your labs. If they're super concerned, they'll reach out to you. Otherwise, it can probably wait till your next appointment. A neighbor told you you should be taking something. They read something, they saw something about amyloid. You need to know, is this something that you should be on? That's something that can wait for your next appointment. Mild symptoms, self-limiting symptoms. So self-limiting means symptoms you had that went away. 4 days of diarrhea, 4 days of hoarseness in your voice. You got a new mole, which maybe looks a little odd. Again, these can wait till your next appointment. When to call your docs. Any new symptom that makes you feel awful, call your docs, always, especially if it's not going away. I think I already saw a question in the chat about dizziness. Patients are dizzy all the time. So if you're having significant dizziness that's not going away, diarrhea, if you've got bleeding, nosebleeds, worsening edema, which is swelling of your legs, shortness of breath, those are all reasons to call your docs. Those are all things that don't need to wait till your next appointment, okay? Unless your next appointment is like tomorrow. When to go to the ER. So none of us want to go to the ER right now. The ER is a horrible place, as you can see by this cartoon. But there's a couple of things with amyloidosis that really need ER attention. One is passing out. All amyloidosis patients pass out. You have a plethora of reasons why you're passing out, but it always needs to be checked out urgently. If you have significantly new or worsening shortness of breath, any bleeding that won't stop, if you've had a nosebleed for 40 minutes and nothing is letting up, you need to go to the ER. Dizziness that's prolonged, you can't even walk, ER. Heart pounding that won't stop, you can get a lot of different heart rhythms with amyloidosis, and sometimes you have to go to the ER so they can put a medicine in your vein to kind of switch it off. And then there's the other reasons why anyone would go to the ER, right? Like significant chest pain, one side of your face drops. Those are pretty important as well. Benefits of a center of excellence. So I'm going to say, obviously, I'm biased, right? I work at the BU Center. It's a center of excellence. I obviously think it's the best place. But in general, there are a couple reasons to seek out a center of excellence. One is at some of them, and I can really only speak to BU, is you get a multidisciplinary approach. So we do not operate in silos here. You see multiple different specialists. All those specialists get together and talk about you, and then someone will, relay that information to you. That's super important. We have a meeting on Friday. The cardiologist and the nephrologist can fight out how much water you should be drinking, and then you'll have that information. The other is access. So access to the most up-to-date research and resources, access to clinical trials, which I'm going to talk about in a second, access to specialty medications. So the medications that are coming out for amyloidosis, whether it's hereditary, wild type, AL, are super expensive and they're hard to get. At the BU Amyloid Center, we have 75 patients getting free drug, free tafamidis, through the patient assistance program. We have a bunch more getting copay assistance. And the reason is our pharmacy has really upped their game to help offer that. And so when you go to a center of excellence, they have those kind of resources so that patients don't get stuck trying to navigate that. Access to other patients with your disease. You know, our waiting room is like a little support group. It's important for you to realize that although this is rare and no one in your family or your extended family or your neighborhood has heard of it, there are a lot of other people living with amyloidosis, and sometimes talking to them is very helpful, and you can make some good alliances that way. Clinical trials. There's a lot of misinformation around clinical trials, that you're a guinea pig. There's no guinea pigs here, okay? So there's a lot of benefits of clinical trials. First of all, you get the expertise of an academic center. Second of all, you can get life-altering medications years before other patients. I think about the people who are trying to get tafamidis, Vyndamax now, who, you know, we offered them that clinical trial in 2015 and they thought it sounded weird, so they didn't do it, and now they can't get it because it's too expensive. So it is extremely helpful for most patients. You get close clinical follow-up. So there's actual data that show patients who are in clinical trials, even if they're not getting the drug, if they're on something called placebo, actually do better. And the reason is you're coming in more. You're seeing a clinician who is an expert in your disease all the time. You get much closer follow-up than you would if you were not on a clinical trial. And, you know, without clinical trials, we don't have treatments. So it's extremely important to, if you're eligible, to really think about it, because it's helpful for you and other people with a disease. Now, what if you can't get to a center of excellence? So first of all, exhaust some resources. Obviously, you guys are on this webinar, you know about the Amyloid Research Consortium, spread the word about that because they can be very helpful. There's an Amyloidosis Foundation that can help. We're living in the world of GoFundMes. I would say it's probably worth it to go to a center of excellence at least once if you can get that through a GoFundMe. And sometimes you have to fight for it. So the insurance issue is a huge issue. And what happens is the insurance company has non-medical professionals who say, oh, this person has AL amyloidosis. That's a blood disease. They can just see a blood doctor locally. No, you need to appeal this. You need to enlist the help of your local doctors. Request that they do peer-to-peers with the insurance company to explain why you need to go to a center of excellence. If you have the means to do it, I've had several patients who have sent letters signed by attorneys to their insurance companies, and that seems to get a pretty good response. And then, you know, there are patient message boards on Facebook and Yahoo. There's no clinicians on there, it's just patients. You know, reach out to them, see how they were able to swing it, see if they have any good ideas. Because again, there's power in knowledge. But if you can't do that, then what can you do? Search for an acceptable alternative. So this goes back to knowing your disease. So if you have hereditary TTR, you want a good neurology and cardiology program because those are likely the organs that are affected, okay? If you have wild type, you need a good cardiologist. Orthopedists are kind of like a dime a dozen, you know, they just inject everything. But you do need a good cardiologist who's up to date on research if you have wild type TTR. If you have AL, the captain of your ship is going to be a hematologist. And then if you have AA, rheumatology is helpful because even if they can't find an underlying inflammatory disease, the drugs that are used to treat AA are drugs that rheumatologists have been using for years. So they're the most experienced with them. So you want to look for a hospital that has a good rheumatology program. The other thing is, it's perfectly okay for you to ask your clinicians to call. I can't really speak for other centers, but we have clinicians calling us all the time, asking us questions, asking us advice. And we triage those calls from all over the country. And that's okay for you to do. It's easier for us if the clinician calls, because then we can kind of talk like clinician to clinician than having the patient call, because you might not know all the words we're asking and that kind of thing. But it's totally okay for you to enlist the help of your local physicians to do that. When you're interviewing these other centers, because you can't come to a center of excellence, things to ask. Are you familiar with amyloidosis? It's okay if they're not. It's okay if they say, I'm really not, but I am willing to do whatever it takes to learn about it. That is a good clinician. That's an okay answer. What types of amyloidosis have you treated? This is a trick question. It's a good question because A, it makes them have to tell you if they even know if there's different types. Okay, so if they're hedging a lot, or they don't even know there's other types of amyloidosis, that's not great. Do you have a nephrologist, a cardiologist, a pulmonologist, or whatever ologist that you like to work with? So this is why it's important to know what organs are involved, because you're going to want, if you have AL, you're going to want a hematologist who maybe works closely with a nephrologist. If you have TTR, you probably want a cardiologist who works closely with a neurologist, okay? So that's why knowing what organs are involved are so important. This is the best question. This is the question I tell my family members. Would you be comfortable if I obtained a second opinion under your care? I've worked with a lot of physicians. There is not one of them who would ever be offended if a patient said this to us. Any good clinician would welcome a second opinion. So if they hedge on that or they say, oh, that wouldn't be necessary, I would probably walk out of that office. And lastly, I just want you guys to know there is so much hope, okay? This is the Twitter handle for BU Amyloidosis and myself, but there is so much going on in amyloid right now. You know, we have a whole journal about how your proteins misfold that we submit research in and read every month called Amyloid, Journal of Protein Folding Disorders. There's the Amyloidosis Foundation that is helpful. The amyloidosis support group, you know, our clinicians go all over the country to help with this. There's an International Society of Amyloidosis. We're all going to Heidelberg, Germany in September to further research so we can get further cures for this disease. There's Alnylam, which is making lots of great drugs for hereditary and wild type TTR. Mayo Clinic, Excellence Center of Excellence. Pfizer, they're the ones who came up with tafamidis or Vyndamax for wild type TTR. Of course, you guys have ARC, which is a golden resource. I am obviously biased about the BU Amyloidosis Center. And then, you know, you guys have Isabelle, you have me, you have lots of resources out there. If you have questions or if you have people that can't get to us, you know, please feel free to use us, use the resources you have if anybody needs help at all. And that is it for me. So I'm going to stop my sharing so we can get into these Q&As, which is freaking me out because it just keeps growing. I can see it.
So first of all, Lisa, phenomenal. You are a force to be reckoned with, and just so clear and concise, and things that patients should consider, ways to do this thoughtfully. And I love one of the first questions that came to my mind, and I know others have this, is, and you sort of touched on it, but, you know, how do you respectfully ask for a second opinion if you're already with a team, and is there a good way to do it from a physician perspective?
I think it's like at BU, I mean, we've had patients who say, I'm going to go to the Mayo Clinic next week, and we're like, awesome, like, cool, that's great, because like we want to know if they're going to do anything different. So I don't think so. I think patients put more on that than we do. I think it's, you know, I'd like to get a second opinion. It's a rare disease. I'd like to get a second opinion. I think that's a perfectly respectable way to do it.
Excellent. So there are a couple of questions that were out here about AL and wild type, and can you have light chains and have wild type? Is this something patients should be concerned about? Is that something you see?
Oh yeah, so it is something we've seen. So you can have wild type and have something called an MGUS, a monoclonal gammopathy of undetermined significance. And we actually wrote a paper on that. About 45% of wild type patients do have that. So if you have wild type, I wouldn't worry about the light chains. They're not a marker of your disease, but you probably are going to need to see a hematologist like at least once for them to reassure you that this is just an MGUS, which is something that happens in older people.
One question, as you mentioned about going to the ER if you have certain symptoms, what do you think, what's the most important thing people should relay about their amyloidosis that tell the hospitals?
That is an excellent question, whoever asked that. So I think, because you're going to the ER, they might not even know what amyloidosis is, right? So it's good to keep things succinct. So I have this type of amyloidosis, light chain amyloidosis. It's like a cancer, and the organs that it's in are the heart and the kidney. And this is the contact for my primary provider, whoever that is, a cardiologist or a hematologist. I think that's very important. If you have TTR, I have wild type transthyretin amyloidosis. I've had it for this long. It's primarily in my heart. This is my primary cardiologist.
There's a really interesting question that just came in, because I know you touched on this right in the beginning, but what are the chances of misdiagnosis between the amyloidosis types? And even, does this even happen at a center of excellence?
Not at our center, but it definitely happens. So it is becoming a huge issue. It's worse than it used to be. And the reason is TTR used to be diagnosed by a heart biopsy, so there was no questions. Now there's this non-invasive nuclear scan, but that scan can also be positive in AL. So that's why you're seeing that rate of referrals, false positive referrals go up, is because of this nuance. So I don't know the actual number in terms of misdiagnosis, but I can tell you that it definitely happens, and it happens at some pretty significant academic centers.
And I think that really touches on the fact that there is no single simple diagnostic test. We see this whole array of tests that are done. And so if you're not responding well to a treatment you're on, seek a second opinion, question the diagnosis. I think that's something to be mindful of. Definitely. Interestingly, this is something Lisa and I talked about when we were putting this talk together. Somebody asked if there's a chart that shows a range of different enzymes and biomarkers and things that you should be tracking. And actually, it's something we've discussed that doing after this, because it's really hard to know whether something's, how much it's varied from the norm, whether it's still in an acceptable range. And I think it's empowering for patients to be able to track their results to see how they're doing, and also know if something comes to a range that's really of concern and changes possibly their course of care. So we will get back to you on that. We will keep that posted, but hopefully we can lure Lisa in to work on this with the ARC team. There are quite a number of questions that are around specific symptoms, and I don't want to throw all these at Lisa. We'll definitely, any questions that are asked, we will get answers to you individually afterwards if they're specific. But there are, a few that, and you've mentioned spinal stenosis being very common. And is that something that's dealt with within an amyloidosis center of excellence? Is there some recommendations about how do you deal with that?
So spinal stenosis is something that is common in the general public as well. So the management of that can be done through your local physicians. So it's more that I want patients to know that it's from their amyloidosis. But in terms of management, it's managed through injections, physical therapy, surgery, although surgery is a little iffy. So there's a lot of that that's managed. But definitely that's something primary cares are used to dealing with. That's something they can refer you to the right specialist for.
And somebody asked, there's a couple of questions around finding a center of excellence, and you talked very eloquently about them. And two of questions come to mind, one of which is, does it vary? Are all centers equal for all types? Or if you have wild type that's more about heart involvement, are there more centers potentially that are available if you have wild type that would be considered centers of excellence per se?
Yeah. So I think because wild type is becoming much more common, and because it tends to be the captain of the ship tends to be a cardiologist, there are like more centers. But in general, you want to be at a center that kind of knows the different types of amyloidosis, because otherwise you end up with the wrong, those are the ones that end up with the wrong diagnosis. Because if you go to a center that only does cardiac amyloid and they're not familiar with the other types, how are they going to know that you don't have the other types?
And along those lines, is there a difference in the sense of urgency of when you should be seeing with which type you have, and what would that look like?
Yes. Dr. Sanchawala is blowing up our chat, but the urgency is very different.
To promote somebody here to speak about
the urgency is very different. So AL is a much more urgent disease. I always say AL goes from 0 to 60 very fast, okay? TTR, hereditary, and wild type, these are slowly progressive chronic diseases. So those are not nearly as urgent as newly diagnosed AL. If you've been told you have localized amyloidosis, meaning like it's on your skin, it's not anywhere else, those are important to be seen, but not urgent.
And international, so we have a number of patients here that are from family members who are from different countries. Is there, we have a unique healthcare system and insurance issues in the US. How does that work for patients who want to travel? Are they all private pay? Do you charge if you speak to their physicians? How does that work?
So again, I can only speak to how we do it at BU, but it is private pay. There's like a fixed price that the hospital we work out of, Boston Medical Center, will charge them to be seen based on kind of what they're getting as far as workup. We try to limit the workup in those patients, so we don't do any like extraneous imaging or labs or things that kind of rack up the charges. As far as international, our director, Dr. Sanchawala, does consults. There is a small fee for the consult, but she will review outside records and talk to your physicians if you cannot come here, which is understandable, definitely.
And well, so many different questions coming in here.
I know.
There was a question which would be helpful, is how do you know if it's localized?
So if it's localized, you need to go to a good center that knows amyloidosis, that will get a panel of blood work, like the ones I showed you on the second slide about those serum and urine immunofixations and those serum-free light chains, and a panel to look at your liver, your heart. They'll do an ultrasound of your heart. So it basically comes down to, if there's no evidence of amyloid anywhere else, and there's no evidence of those light chains being up, then it's localized amyloidosis.
And there are a couple of questions which are around sort of managing side effects and, or not necessarily side effects, but symptom management that can be really impact quality of life, such as, and I think some of these that come up quite often and touched on are both appetite, loss of appetite, changes in appetite, and neuropathy. And are those things that you bring to your amyloid center? How are those best managed?
Yeah, so this is what we call supportive care in amyloidosis. And a lot of times when we write our recommendations, there's like a whole paragraph on supportive care, like ways to kind of tweak things to make people feel better. So a good example is neuropathy, right? Like neuropathy is a horrible thing. It keeps people up at night. Blah, blah, blah. So you need to have a good neurologist. You need to figure out where the neuropathy is coming from. There's a lot of topical agents that are helpful for neuropathy. A lot of different medications, things like massage, mindfulness, all those other things help with those kinds of symptoms. So that can be helpful. Physical therapy, gait training, having someone come to your house and help you figure out if your house is set up safely for you. All those things are important. Loss of appetite. We have people see a nutritionist all the time. Teach them how to do calorie counts. Teach them how to do what we call grazing, right? Because you have loss of appetite. You can't have like 3 big meals a day. Do multiple small meals. What meals are more apt to make you feel more nauseous or full easier? There's actual medications to help with that as well if these other little things are not helping. There's appetite stimulants that can be used as well.
Thank you. So there's a very good question, which I think is really important for patients to understand. You have they're fortunate enough to come to be you or another amyloidosis center. How often do they come to the center? How often do they need to be seen by potentially an amyloidosis expert, maybe regionally? And what do you take to your local physician? How do you manage that care?
Yeah. So this is a difficult one. So we like to see our patients once a year, just to keep our foot in the door. And I will say with COVID, I think we learned that when people put off the evaluation, it tends to not end well, because obviously people couldn't travel to see us, and now we're seeing the downside of that. So I think once a year is good. I think that if you are looking at your labs and you're knowing how things are progressing and you're having great conversations with your local doctors, you should feel very comfortable coming once a year or once every other year. If you're asking your clinicians about those questions I said to ask, and it's like a blank slate, like it is like they have no clue, that's not really great. And you might need to be followed a little closer at a center that has more experience with it. But in general, we do once a year.
And do you send reports back to their local physicians? How does that, if you're putting somebody on a long-term, and we certainly see now with wild type and hereditary, these are treatments they're on for life, right?
Right.
Potentially. So how does that care get translated to their local care team?
Yeah, so we send a report to all the local physicians. Patients fill out a form on who they want it to go to. And we send a report kind of summarizing the disease, summarizing our findings, and then a summary of recommendations. So I say it's kind of like a baking recipe, Number 1, do this. Number 2, do this. Number 3, do this. And it can make patients uncomfortable, because you don't want to feel like you're stepping on your local physician's toes, right? Or, like you're assuming they don't know what they're doing. But you can kind of assume that, like in this disease, and most local physicians I have found are super grateful for the assistance that we're able to give. And they are more than willing to look at what we have provided. And if for some reason they don't agree with it, that's okay too. We've had physicians email us and be like, I kind of think this might be better. And then we're like, oh, maybe that wouldn't be such a bad idea. So open communication with the physicians is the biggest thing.
And I think that's something very important for patients to monitor, that if BU has made or a center has made recommendations and your local physician is changing those, to understand why and to be able to question that, and also sense check back with you that, is this all right? Because sometimes that communication can break down, it can cause concern for a patient, and sometimes there isn't a good reason for changing. So I think that's one of the places where being an empowered patient is really important, to understand what treatment you're given, why, what treatment is being given, why, and if any changes are being made, what the rationale. And it's something, certainly with AL, with multiple organ involvement, there's a lot of titrating and tweaking medications. So that can be quite an important network to really form and manage. So we're at the end of time, and I wanted to say thank you so much, Lisa. You are remarkable, and it's amazing to really hear so clearly such good recommendations. We've had a phenomenal number of participants today, and also been flooded with questions. The ARC team will go through those, and we will make sure that we push any to Lisa that she can answer, and otherwise we'll get those to the right place to answer. But thank you so much. Really was a great webinar, and appreciate it.
Thank you so much for having me. I really appreciate you letting me talk.
Thank you.